Okay, good morning, class. Today I will be taking the class about seronegative spondyloarthropathy. Can you guys listen me? Can you guys listen me? Someone please message. Okay, okay, thank you. Now moving to my topic. Okay, today my topic is seronegative spondyloarthropathy, and I will be talking mainly about the clinical symptom, basic clinical symptom of the seronegative arthritis, and then the diagnostic part, and then that consists of investigation, and then the management. Okay. Now moving to the classification of arthritis. Okay. Now, this is a simple classification. Okay. Simple classification telling about. Did you what's it? Okay, now talking about the classific of the arthritis. Basically, the arthritis are divided into inflammatory and non-inflammatory arthritis. The inflammatory arthritis consists of seropositive, seronegative, infectious, and crystal-induced. Okay, basically there are four inflammatory causes of arthritis, and there are other non-inflammatory causes. So I will be only talking about inflammatory, and also inflammatory I will be talking about the seronegative inflammatory arthritis. I think there is tomorrow there is the class of seropositive, that is rheumatoid arthritis. Okay. Now coming to the introduction. The seronegative spondyloarthropathy. This is basically a group of chronic inflammatory rheumatic disorder, which has the clinical picture of inflammatory back pain. I will be talking about inflammatory back pain. Okay, and the asymmetric peripheral arthritis, enthesitis, dactylitis, tenosynovitis, and which has a genetic predisposition of HLA-B27. Okay, I think if anybody asks you what is seronegative spondyloarthropathy, if you can tell this, then I think the person will know that you have known the basic topic. Okay, because the main thing here is inflammatory back pain, the asymmetric peripheral arthritis, the enthesitis, that is the calcification in the tendon and ligament. Okay, and then the tenosynovitis. Okay, there is a swelling and inflammation of the tendon. Okay, and there is a genetic predisposition of HLA-B27. Okay, and then there are the seronegative. The name seronegative came because these diseases are negative for rheumatoid factor. Okay. Now coming to the same thing, spondyloarthropathy. It basically means there is a arthritis of the spine. Okay, spondylo means the spine, and also the other peripheral joint. Okay, so there is a inflammation. Okay, and then there is also inflammation of ligaments and tendon. Okay, and sometimes also the eye. Okay. Coming to the prevalence. Okay, coming to the prevalence, basically in the outer population, like in the USA, it is about 1%, and the ankylosing spondylitis is about 0.5%. But in case of South India and our part, the prevalence is a little bit high. Okay, and the HLA-B27 positivity status is also high in our part. Okay. Classification basically in 1974 Moll has classified the seronegative spondyloarthropathy into 5 types. Okay, ankylosing, psoriatic, reactive, enteropathic, and then undifferentiated spondyloarthropathy. Okay, now coming to the this is basically the classification for spondyloarthropathy. I mean, thing in this slide is you need to know the modified Newer criteria for ankylosing spondylitis. Okay, this will be asked in the exam. Okay, this is one of the important slide in today's presentation. Basically there is the clinical criteria and the radiological criteria. The clinical criteria consists of low back pain and stiffness for more than 3 months, which improves with exercise, but it is not relieved by rest. Okay, this is a classical symptom of the classical presentation of ankylosing spondylitis, that is seronegative arthritis. Okay, low back pain and stiffness for 3 months, that more than 3 months, that improves with exercise, but is not relieved by rest. Similarly, there is limitation of motion of lumbar spine in both sagittal and frontal. That means he cannot do the flexion extension and lateral flexion. Okay, there is limitation of movement, and another is the limitation of chest expansion relative to the normal values correlated for age and sex. I will be okay. So what I was talking is about the modified Newer criteria for ankylosing spondylitis. Okay, there is basically the clinical criteria and the radiological criteria. The clinical criteria, it has got the low back pain and stiffness for more than 3 months, which improves with exercise but is not relieved by rest. Okay, and there will be limitation of the motion of the lumbar spine, in sagittal and coronal plane. Okay, sagittal that is in flexion extension. Okay, and the limitation of chest expansion is relative to normal value. Okay, so these are three clinical criteria given by neuro criteria, modified neuro criteria, and the radiological criteria. Okay, this will be, I will be talking about this in another presentation. Okay, I got some picture about it. There will be sacroiliitis grade more than 2 bilaterally or grade 3 to 4 unilaterally. Okay, so to define ankylosing spondylitis, radiological criteria is associated with at least one of the clinical criteria. Okay, there should be one clinical criteria along with the radiological criteria. Okay, so then you can see it's a ankylosing spondylitis. Now coming to the inflammatory low back pain. Okay, the basic thing, the basic pain complaint of the seronegative arthritis is inflammatory low back pain. Basically, the inflammatory low back pain differs from mechanical back pain by the age. Okay, usually it's less than 40 years old. Okay, in inflammatory in mechanical back any age. Okay, there will be a morning stiffness. Okay, more than 60 minutes. Okay, and in mechanical it will be less than 30 minutes. And then basically by the activity. Okay, by the activity this kind of pain will be decreased. Okay, and in the mechanical back pain that will be exacerbated or that will be increased by the activity. Okay, uh, basically these are the few points. Now coming to the ankylosing spondylitis. Ankylosing spondylitis is a chronic inflammatory seronegative chronic inflammatory disease that affects the axial skeleton, the peripheral joint, and the tendons. Okay, tendons and ligaments. Sometimes the eyes are also involved in the form of uveitis. Okay, and there will be a family history. Usually there will be a positive family history for ankylosing spondylitis. And the main symptoms are the pain, muscle stiffness, decreased function, decreased activity, and there will be some sleep disturbances. Okay, sleep disturbances, and then psychological problem, depression. Okay, so HLA-B27 is found in more than 90% of the patient. Okay, in AS. Now coming to etiology, it is a genetically predetermined and autoimmune immunopathological disorder. These are common in SLA-B27 positive patient. Okay, and basically these are triggered by various triggering factor. Okay, I think there are long list that can trigger, like the cold weather, the virus. Okay, any infection, any immunodeficiency condition can initiate the abnormal immune response. Okay, and then the HLA-B27 patient, they will manifest as a ankylosing spondylitis. Okay, basically you need to know that is SLA-B27 positive patient. If there is any triggering factor, then it will initiate an abnormal immune response. Okay. Now coming to this is a simple. Okay, this is a simple picture showing about the normal inflammation, erosion, and the syndesmophyte formation. That is classical of ankylosing spondylitis. Okay. Now coming to the main these are the three steps. Okay, these are the three steps you need to remember about the pathology of the ankylosing spondylitis. If there is abnormal immune response in HLA-B27 patient, there will be an inflammatory reaction. Okay, with cell infiltration, granulation tissue formation, and erosion of the adjacent bone. And these erosion will be replaced by the granulation tissue, right? Fibrous tissue. Okay, and then finally there will be ossification of the fibrous tissue leading to ankylosis. Okay, leading to the fusion of the joint. Okay, so these are the three steps you need to remember. Okay, the pathology regarding the pathology of ankylosing spondylitis. You can see the picture. There is a healthy spine, and then there is some inflammation in the joint in the disc. Okay, and then there is the fusion. There is ossification and the fusion of the bone. Okay, the similar picture is showing that the bamboo spine is showing in the picture. Okay, in the X-ray. Now, the clinical features, the main clinical feature is the inflammatory back pain. Okay, inflammatory back pain with sacroiliitis, because the sacroiliitis is the first complaint of a patient in the ankylosing spondylitis. Okay. Are you getting up to clinical? Okay. Thank you. So these are the this is the clinical other clinical features are the peripheral arthritis. Enthesitis means the is the inflammation and the calcification of the tendon and the ligament. Okay, and the anterior uveitis, and also there may be other manifestation in the other organ. Okay, and basically the physical finding is the spinal stiffness, loss of spinal mobility, structural damage, limited expansion of the chest, and the lumbar lordosis. The lumbar lordosis will be lost. Okay, Now coming to the examination, okay, there are some tests, okay, Sober's test, modified Sober test, lumbar side flexion, tragus to wall, cervical rotation, intermalleolar distance, chest expansion, okay. So basically, I'll be talking about the Sober's test, okay. So in this picture, you can see this is the modified Sober test, okay. In the Sober test, what is difference between Sober and modified Sober is basically the in Sober test usually we'll take a marking in the level of PSIS. We take a marking in the PSIS. Okay, we take the marking in the PSI and 10 centimeter above it. Okay, and then we'll ask the patient to bend forward, and there will be a minimum excursion of 15 centimeters. So there will be more than 5 centimeter excursion. So this will tell that there is no stiffness. Okay, and the modified sugar will do 5 centimeter below the PSIs. Okay, we'll do 10 centimeter above the PSIs and 5 centimeter below the PSIs marking, and then it will be up 15 centimeter, and then we'll ask the patient to bend forward, touching the both hand to the feet. Okay, and then it should be more than 20 centimeter. Okay, so this will test the lumbar and sacral excursion. Okay, if there is no stiffness, if there is normal excursion of the lumbar and sacral vertebra, then it's less likely to be a ankylosing spondylitis. Okay, so this is the modified Sober. The picture showing here is modified Sober test. Okay, and then similarly the chest wall expansion. Okay, if there is in the full expiration and the full inhalation at the level of the nipple, okay, that is in the fourth intercostal space, if there is a difference is less than 2 centimeter, then it is strongly there is suspicion of the ankylosing spondylitis. Okay, now, coming to the the laboratory diagnostic procedure like the erythrocyte sedimentation rate, these are increased, okay. The C-reactive protein, these are the markers of inflammation, okay, they are also raised. The HLA-B27 antigen can be detected is around 90% of the patient, okay, and the typical X-ray picture I'll be showing later, okay, and MRI scan can be done to identify the early sacroiliitis, and I'll be showing the radiological grading of the sacroiliac in the later slide. Okay. Now coming to the radiological grading of the sacroiliitis. This is the very basic investigation. Okay? This is a plain X-ray of the sacroiliac joint. Okay, you can see from a simple X-ray we can give a diagnosis of along with the clinical picture with the X-ray we can give a diagnosis of ankylosing spondylitis. Okay, so there are so the grade one, there is a reduced demarcation of the joint space. I think can you appreciate it in the picture A? Okay, there is a slight decrease in the joint space. Okay, and the grade two, there are localized area of the erosion. Okay, in the you can see in the picture there are small localized area of erosion and subchondral sclerosis. Okay, the white part, the glistening part of the sclerosis. Okay, that is the grade two, and in the grade three there is a sclerosis and erosion with partial ankylosing of there is partial fusion of the joint in the grade three in the C, and in the four there is a total ankylosis. Okay, total ankylosis of the joint. You can see in the D. This is the grading. Okay, radiological grading of the sacroiliitis. Now coming to the X-ray. Okay, these are the typical X-ray feature of a patient with ankylosing spondylitis. In the picture one, in the first one, you can see the shiny corner. Okay, there is erosion and then there is the sclerosis. Okay, so this is the Romanus lesion and also as shiny corner sign. Okay, in the second picture, you can see there are the ossification of the paravertebral area. Okay, including the ligaments. Okay, including the disc, outer layer of the disc. Okay, that is the endless fibrosis. Okay, there will be the calcification, and that is also called as the bamboo spine. You can see in the middle picture. Okay, and in the left side, in my right side, you can see there is a breaching syndesmophytes. Okay, these are some. I think you can see here there is a breaching osteophytes. Okay, these are basically syndesmophytes. This arise from the tear annulus fibrosus, the outer part of the disc, and there will be ossification, and uh, along with the vertebra. Okay, there will be a paravertebral ossification at the outer layer of the disc. So these are the breaching syndesmophytes. Okay, these are the classical picture of the. This is the classical picture of the syndesmophyte. Okay, we can see here also. They are slightly raised. It is slightly raised, and it is going upward. Okay. Whereas there is osteophyte. Osteophytes are more horizontally oriented. Okay, they are not. They do not breathe together. Okay, they will be more horizontal. Okay, these are vertical. These seamless move flights are vertical. Okay. Now, these are the some railroad track sign. Basically, this is showing this. There is ossification of the ligament, okay, around the neck, okay. So this will give the railroad track sign. Similarly, the dagger sign. These are the ossification of the interspinous ligament, okay. And this shows the dagger shape of the dagger, okay. And now coming into the management part consists of the medical, biological, and physiotherapy management. Medical management is the first line of treatment is okay. The first line of treatment is the non-steroidal anti-inflammatory drug NSAIDs. This improves spinal pain, peripheral joint, and function over a short period of time. And basically, these don't prevent or retard the progress to the bony fusion, but it will relieve the symptom. Okay, and other one is the steroid. Okay, one is the steroid. Okay, I have mentioned here, after the NSAID we can give a short course of steroid. Okay, this will basically delay the inflammation. Okay, delay the inflammation, and this will provide a time for the action of the other other biological or other demands. Okay, other disease acting for the ankylosing spondylitis like methotrexate, sulfasalazine. Okay, so for the bridging therapy is also called as bridging therapy. We can use the short course of the steroid. Okay, now these TNF inhibitors, these are the biologicals. Okay, these are the biologics. These are the T1 necrosis factor inhibitor. They are the etanercept, infliximab, adalimumab, golimumab, sortolizumab. Okay, these are approved by the FDA for the use of the ankylosing spondylitis, and these are indicated only after the treatment after the NSAIDs therapy. Okay, if they fail, if there is failure of the NSAID therapy, and there is given the short course of steroid, and if they didn't work, then you need to go for the biologics therapy. Okay, TNF. Now, similarly, other drug are like the similar drug like which you use in the rheumatoid arthritis. Okay, the methotrexate. Okay, the sulfasalazine. Okay, and then the gold, sometimes gold. Okay, then leflunomide. These are other uh, disease modifying anti-rheumatic drug. Okay? They are also called as DMARDs. Okay, I think that will be detail. That will be talked detailedly in tomorrow's topic. Okay, regarding the rheumatoid arthritis. Okay, DMARDs. DMARDs can also be used in case of ankylosing spondylitis. Basically, the methotrexate, sulfasalazine, and leflunomide. Okay, these are basically these three drugs are commonly used nowadays. Okay, and the other main other drugs have other drugs azathioprine. These drugs basically have side effects and they are being removed. Okay, and these TNF inhibitors, these are the biologics. Okay, biologics, and before using a biologics, we should rule out the active infection if there is any active infection in the body like TB. Okay, if there is tuberculosis, and these biologics will flare the tuberculosis. Okay, so you should be careful while using these TNF tumor necrosis factor inhibitors like etanercept, infliximab. Now coming to the surgery, okay, if there is the fusion of the joint, if there is fusion of the hip and knee, then the patient will have significant benefit with the arthroplasty, and we should be worried about some heterotropic bone formation after joint replacement in case of ankylosing spondylitis, and this heterotropic bone formation can be reduced by giving NSAIDs. Okay, that is the indomethacin. Okay, preoperatively and postoperatively, and employing the radiation therapy. Okay, radiation therapy postoperatively for heterotropic ossification. Okay, and some people also, some surgeon, they will start indomethacin preoperatively, and radiotherapy preoperatively for preventing heterotropic bone formation. Now coming to the physiotherapy management. This is another main management for the treatment of ankylosing spondylitis. Its basic aim is to alleviate pain, increase spinal mobility, functional capacity, reduce morning stiffness, okay, and then correct postural deformity, okay, and treatment is essential to minimize or prevent deformity. These are some of the picture. These are some of the picture to be done by the ankylosing spondylitis patient, okay. Uh, and then the main thing here is for the elevation of the pain or increasing the spinal mobility and functional capacity. Okay, and to reduce the morning stiffness, correct postural. These are the principle. Okay, principle. These are aim. Okay, these are basically the aims of the physiotherapy management. You should do more. Okay. Now Coming to the Retter's syndrome, this is another seronegative spondyloarthropathy. Retter's syndrome is also called as reactive arthritis. Okay, these are synonyms. Okay, that develops in response to a infection and characterized by a triad of arthritis, conjunctivitis, and bacterial urethritis. Okay, so it is an autoimmune disease. Autoimmune disease by inflammatory synovitis, marked by inflammatory synovitis, and then erosion at the insertion site of ligaments and tendons. And basically, this also has the HLA-B27 genetic marker. Okay, and there is a strong prevalence of Rett syndrome in individuals with HIV. Okay. Now coming to the causes, basically this is usually Retter syndrome usually follow an episode of bacillary dysentery, which is a bacterial infection. Okay, and then most of the organism involved in Retter syndrome are chlamydia, salmonella, shigella, yersinia, and campylobacter. Okay, this is important. Okay, you should know the organism: chlamydia, salmonella, shigella, yersinia, and campylobacter. Okay, these are the most common cause of infection in Retter's. Okay, Retter syndrome. Okay, and this can be manifested from sexually transmitted disease or contaminated food. Okay, and Retter syndrome cannot be transmitted from person to person. However, the bacteria that triggers can be passed from one person to another. Okay. Now coming to the clinical triad. Okay, these are the clinical characteristics, and these are the clinical triad: urethritis, conjunctivitis, and arthritis. Okay, this is the main thing, the main triad of the reactive arthritis. And there will be a other than that, there will be a polyarticular arthritis in the large joint, in the knee, ankle, post-metatarsal joint. Okay, and then there will be other uveitis, keratitis of the cornea. Okay, there will be some fungal infection can be there. And similarly, the enthesitis. Okay, the Achilles tendon, ischial tuberosity. There will be the inflammation and later calcification of that part. You can see in the picture the triad: reactive arthritis, the urethritis, conjunctivitis, and the arthritis. Okay, and these are the picture. Okay, this is showing the uveitis. Okay, systemic involvement is musculoskeletal manifestation. Skin lesion can be there, like in psoriasis. There will be a constitutional symptom like malaise, fever, fatigue, weight loss. Cardiovascular involvement like aortitis, aortic insufficiency. Okay, and then associated comorbidities like maybe presenting symptom of the HIV. Okay, diagnostic test similar to the ankylosing spondylitis. There will be ESR, CRP will be raised. Sometimes certain type of bacteria can be seen in the urine sample, in the genital swab or stool culture. There will be radiological feature will be ill-defined erosion, enthesopathy, bone proliferation. Okay, and uniform joint space loss. This is the important thing in Retters. Okay, there will be a juxtaarticular osteoporosis, uniform joint space loss, and a fusiform soft tissue swelling. Okay, this will be different from the ankylosing spondylitis. And then the MRI is the diagnostic imaging of choice to help diagnose Retter syndrome. The affected bone will present with a moth-eaten appearance, bony expansion, and loss of cortical definition. Okay, the main thing here is juxtaarticular. There will be osteoporosis around the joint. There will be uniform loss of the joint space. Okay, and there will be a fusiform soft tissue swelling of the joint. Okay, the medical treatment. Medical treatment is similar to the other arthritis. Like there will be, these are treated with NSAIDs, but the main thing here is to treat the bacteria we need to use a tetracycline or erythromycin 500 mg taken orally 4 times a day for 10 days is recommended. Okay, and mainly for the due to sexual exposure. Okay, and then for the conjunctivitis or mucocutaneous lesion, although no treatment is necessary, but you can use a topical glucocorticosteroid. Okay, and similarly, you can treat the enthesopathy with a local injection of steroid, but these are short term. Okay, these don't have a long term effect. Sometimes this local steroid injection may weaken the tendon. Okay, and then that can also cause the rupture of the tendon. Surgical treatment is rarely indicated, but sometimes you can do a synovectomy, fusion, or tendon repair. If there is joint swelling, or there is a synovial proliferation. Okay, or if there is instability of the joint, you can do a fusion. Or if there is tendon injury, then you can do a repair. Similarly, the physical therapy management. Okay, similar to the ankylosing spondylitis, patient education. You need to promote the joint range of movement, some aerobic exercise, immobilization and inactivity are discouraged. The goal of the treatment should be pain relief, improve activities of daily living, reduce joint swelling, prevention of joint damage and disability. So there should be some movement, there should be some exercise, there should be some aerobic exercise, and immobilization and inactivity are discouraged. Now coming to the another spectrum of the seronegative arthritis. That is the psoriatic arthritis. Okay, as the name suggests, there is a relation with the psoriasis. Okay, so this is a chronic progressive inflammatory joint disease that can be associated with psoriasis. Okay, that may not be associated also, but usually they are associated with psoriasis. And the clinical picture will be, there will be a peripheral joint pain, and also there will be pain, stiffness, swelling, and possibly joint destruction. Okay, and these are more this pathology progresses slowly, and can be more of a nuisance than disabling. Prevalence is 6% to 40% of people that have psoriasis, and approximately 2% of general population has psoriasis. So 6 to 42% of the psoriasis population can have psoriatic arthritis. This is equally prevalent in both male and female. Okay. Now coming to the causes, the first degree relative psoriatic arthritis have increased likelihood. Okay, the environment factor, sometimes the trauma and infection may trigger the psoriatic arthritis. Immunological, like the cytokines have been found in high abundance in the joint with the psoriatic arthritis. Okay, and the cytokines are the inflammatory mediators. Basically, they are the inflammatory mediators that are released when the T cells are activated. Okay, these are the retrospective finding. Okay, because the tumor necrosis factor, these are abundantly found. The T cell are found. Okay, so this will be helpful in the knowing the pathology. Okay, and the pathology and some targeting some medication. Okay. Now coming to the clinical presentation, okay, of the psoriatic arthritis. To remember, there is basically five clinical presentation. One is the involvement of the joint is distal. Okay, in the, if you I think in tomorrow class you know, in rheumatoid arthritis the involvement of the joint is usually the proximal interphalangeal joint. Okay, the distal interphalangeal joint is involved in psoriatic arthritis, whereas the proximal interphalangeal joint are involved in rheumatoid arthritis. Okay, you may RA, that will be taught next day. Now so coming to the symmetric arthritis, this typically resembles rheumatoid arthritis. Okay, five or more joint will be involved. And asymmetrical swelling. Okay, some joint may have very huge swelling, some have very less, some may be very red, some may be less red. Okay, there will be asymmetric swelling, as asymmetric feature of the joint. Okay, and spondylitis, that is the inflammation of the spine. Okay, and neck, low back, sacroiliac joint are often affected. This arthritis mutilans is, it is seen in very rare case, but this is the most severe and destructive form of the arthritis. Okay, there will be sudden rapid destruction of the joint. Okay, giving the appearance of sausage. Okay, there is sausage appearance. There may appear sausage due to sudden swelling and sudden there will be rapid destruction. Okay, but it occurs in 1% of all cases. Okay, this is the arthritis mutilans. So these are the five peculiar clinical picture of the uh, psoriasis. Are you getting? All of you are getting? বুঝে আছো? শুনিरहेको छ कि छैन? Okay. Now coming to the, so these are the picture. You can see the psoriatic. This is the psoriatic nail. Okay, nail bed, nail, and there is the psoriasis. This is the lesion. This is the enthesopathy. There is the swelling in the Achilles tendon insertion. Okay, and then you can see the eye involvement. Okay, and then the distal. You can see there is the distal interphalangeal joint. Okay, the proximal interphalangeal joint are relatively normal, and there is uh, swelling. There is swelling of the, there is swelling, and there is some deformity of the distal interphalangeal joint. This is a peculiar feature of psoriatic arthritis. Now coming to the diagnostic test, there is no definitive test for psoriatic, but X-ray are thought to be a gold standard. Okay, and then there will be we can use ultrasound or MRI to know if there is any inflammation in the joint or not. Okay, now this is the peculiar picture of the psoriatic arthritis. As you can see in the, there is the involvement of PIP. Okay, sorry, the DIP, distal interphalangeal joint. The PIP looks normal. Okay, near normal. Okay, so there is juxtaarticular osteoporosis. You can see around the joint there is some osteoporosis. Okay, and then there is the asymmetrical lesion. Okay, asymmetrical lytic lesion over the joint. Okay, okay, and if it progress rapidly, and then it can turn into arthritis mutilans. Okay, but it is only in 1%. So this is another picture, another joint of the distal interphalangeal part. There is asymmetrical joint swelling, joint destruction. Okay, you can appreciate it. Okay, I think you can appreciate it. In case of reactive arthritis, the joint will be symmetrically involved. Okay, there will be, but in case of psoriatic, there will be periarticular inside the joint, the cartilage will be destroyed. Okay, so it will be slowly progressing. Usually, this psoriatic arthritis will be slowly progressing. Okay, and the difference from RA is RA will affect the proximal interphalangeal joint. The psoriatic arthritis will affect the distal interphalangeal joint. Okay, as I have mentioned. Okay, there will be asymmetric swelling and asymmetric destruction. Okay, of the joint. Okay, in case of psoriatic arthritis. Now, the similarly HLA-B27 workup can be done, but the incidence is I think around 50 to 60%. Okay, in case of psoriatic arthritis, HLA-B27 is 60%, around 60% can be positive. And similarly, when you do a RA factor to rule out rheumatoid arthritis, antinuclear antibody can be done to rule out lupus. I think you have heard about lupus nephritis, I think. Okay, and the CBC, these are routine tests. And sometimes you may have to aspirate the joint, okay, to rule out infection. You may have to do a arthrocentesis, okay, the joint aspiration, rule out the infection or any crystal deposition disorder, okay. So any crystal deposition disorder or some other pathology, okay. Basically, the infection, the crystal deposition disorder, and white blood cell, okay, to rule out it. Now coming to the differential diagnosis, I think this will be easier for you. What will be the differential diagnosis? That is the peripheral spondyloarthropathy, osteoarthritis, fibromyalgia, gout, and ankylosing spondylitis. These are some rheumatic condition that can mimic psoriatic arthritis. Okay. Medical management similar to previous one, but here in case of mild disease, look the NSAIDs, the paracetamol, okay, and the local corticosteroid injection that can be used, but it can flare up the psoriasis. Okay, so in mild disease you can use it, but you need to be careful. Okay, moderate to severe disease, as I have been talking, the disease modifying anti-rheumatic drugs. These are slow acting drugs, but this will suppress the disease activity, so these are helpful. Okay, the methotrexate, sulfasalazine, leflunomide, okay, these drugs are helpful in moderate to severe disease. Okay, and similarly the anti-tumor necrosis factor and the biologics like adalimumab, etanercept, golimumab, infliximab, these are very helpful if the NSS or DMARDs are not responding well. Okay, there is another drug, the Otezla, the new drugs. This has been, I think, this has been approved in 2014. These are the oral phosphodiesterase 4 inhibitor, and this will help in increasing the anti-inflammatory mediators. Okay. Now coming to the physiotherapy management, similar, there should be education, improvement of range of motion, strengthening, and general cardiovascular conditioning. Okay, and this is very important. Physiotherapy part is also important in psoriatic arthritis. Now the rehabilitation programs, we have rest, exercise, the modalities like heat and cold treatment, orthopedics, upper and lower extremities, assistive device for gait, and education about the disease. Okay, and the joint protection, and the patient will be counseling about the prolonged rest. That is harmful in this kind of disease. So there should be regular activity. Okay. Now coming to the, I think the last one, the enteropathic arthritis. The enteropathic arthritis, I think you have known, I think you have also read in medicine, general medicine. These are the two forms, okay, of inflammatory bowel disease, that is the ulcerative colitis and the Crohn's disease. Okay? These are also part of the spondyloarthropathy, okay, seronegative spondyloarthropathy. These are two types of component. One is peripheral arthritis, and the other is the sacroiliitis and the spondylitis. Okay, peripheral arthritis means there will be involvement of peripheral joints, and there will be another part with the sacroiliitis. The sacroiliac joint will be involved, and spondylitis means there will be inflammation, there will be stiffness, there will be problem of the spine. Okay, so these are the extra-intestinal manifestation. I think you know the intestinal manifestation of ulcerative and Crohn's disease, and these are the extra-intestinal uveitis, pyoderma gangrenosum, erythema nodosum, and finger clubbing. Okay, this is showing the pyoderma gangrenosum. Okay, these are the extra-intestinal manifestation of the inflammatory bowel disease. Laboratory finding, in case of 30 to 70% can carry the HLA-B27 gene. Okay, and radiographic changes in the exhalation are same. Okay, as in case of uncomplicated ankylosing spondylitis, the radiographic changes are similar. Okay, the main difference is it has called the bowel complaint. These are the inflammatory bowel disease with peripheral arthritis peripheral arthritis with spondylitis with sacroiliitis. Okay, so the basic difference will be the bowel complaint. Okay, the gastrointestinal complaint, the problem will be there. Okay, so these are the basic few important seronegative arthritis. Okay, so anybody want to ask some question? Okay, if you didn't get any topic, any part, I think you can message. Okay, did everyone got all the slide? सबैले सबै पढाएको बुझ्यो? Okay, I think I have got some questions. Okay. Okay, X-ray. Okay, you want to see some X-ray. Okay, okay, I will say. So this picture basically shows the bamboo spine. Okay, you can see there is paravertebral ossification. Okay, and also the outer part of the disc annulus fibrosus. Okay, that will be ossified, so it will give appearance of bamboo. This is the bamboo spine in ankylosing spondylitis. I think someone has mentioned about the sober test. The sober test is basically for looking for the excursion, okay, the movement of the lumbar region. Basically, the sober test was given for lumbar region, and modified sober test is given for lumbosacral region. Okay, the movement, if there is any movement or not, if there is any excursion or not, and the patient is kept in the standing position. Okay, will be marked. These are the dimple of Venus. Okay, this is the posterior sacroiliac joint, and center of it will be marked as 0 and it will mark as 10 centimeter. Okay, and then we'll ask the patient to bend forward, and in the excursion or the movement should be more than 5 centimeter. Okay, it should be 15, more than 15 centimeter to say it is a normal. Okay, this is the sober, and to have to for the modified sober, you will extra mark it 5 centimeter below the 0 point. Okay, and then you will ask the patient to bend. Okay, and then we'll do, and if you calculate the total distance now, it will be 20 centimeter, okay, showing that there is a movement, there is an excursion of the joint. In ankylosing spondylitis, there will be no excursion, there will be stiffness, there will be no movement, so it will be less than 20 centimeter in modified sobers, and it will be less than 15 centimeter in total in sober test. Okay, basically in sober it looks for lumbar excursion, and in modified sober it looks for lumbar and sacral excursion. Okay, and I think, am I clear about sober test? Am I clear about sober test? Sober and modified sober. Okay. Now coming to some X-ray. Okay, this is a radiographic grading of the sacroiliac joint. In stage 1, there will be some alteration. Okay, it's very difficult in stage 1, and it seems more like a normal X-ray. Okay, so you can see some of the changes here. Okay, there is slight reduce in joint space, and in number 2, you can see some dot. Okay, some dot in the edges. Okay, some dot in the edges. These are the sclerotic. Sorry, these are the localized erosion and subchondral sclerosis, the white part. These are subchondral. And in C, you can see the partially fusion. This part are partially fused. Okay, these are slightly normal. These are fused. And in 4, in grade T, all are fused. Okay, and this is the Romanus lesion. Okay, Romanus lesion is basically there is the anterior part, the most anterior part will get eroded. Okay, as I have mentioned in the pathology. Okay, in ankylosing spondylitis there will be erosion and inflammation of that part, and it will be replaced by fibrous tissue, and then the sclerosis. There will be some sclerosis. Okay, that is the sign corner sign. So it will be sign. It will look like signing in the X-ray. This is the signy corner sign, and the bamboo sign you can see in the middle, and this is the syndesmophytes. Okay, these are the syndesmophytes. There will be ossification over the annulus fibrosus and the longissimal ligament. Okay, in the paravertebral tissue. So this will be as a both side. Okay, these are the ossified. This is the railroad track sign. Okay, the dagger sign in the interspinous. There is calcification of the interspinous ligament. This seems like a dagger. Okay. Okay, I think. Uh, okay. This is a picture of psoriatic arthritis. Okay, I think I have mentioned. This is the proximal interphalangeal joint. This is the distal interphalangeal joint. There is the lesion in the distal interphalangeal joint. It is asymmetric. There is asymmetric swelling. Sometimes it can goes to a arthritis mutilans. Okay, there can be rapid destruction. Okay. Anymore, how is IBD related to arthritis? Okay, inflammatory bowel disease has got a autoimmune component. Okay, it has got also the marker as HLA-B27. This is basically a marker. Okay, HLA-B27, this makes genetic predisposition. Okay, so in fact I think 20 to 60% around it has got the HLA-B27. Okay, that genetic predisposition will lead to the peripheral arthropathy, peripheral spondyloarthropathy, and the feature like ankylosing spondylitis. Okay, so inflammatory bowel disease also has got extra intestinal component that are the spondyloarthropathy that mimics the spondyloarthropathy, and that has been kept as a seronegative spondyloarthropathy. Since the RA factor and anti-CCP, these are negative. Okay, ANA, these are negative, so they are kept in the seronegative spondyloarthropathy. And the HLA-B27 is I think around 20 to 60%. Okay, uh, in ankylosing spondylitis is 100%. Okay, sorry, 90%. In other spectrum of seronegative, the HLA-B27 predisposition will be reduced gradually. Any more questions? Okay, I think we are in the last. We have got few minutes. Did you get it? The inflammatory bowel disease, how it is related to arthritis. Okay, basically it is an autoimmune condition. Okay, inflammatory bowel disease is also autoimmune condition with HLA-B27 predisposition. HLA-B27 predisposition. Okay, so that leads to the that leads to the spondyloarthropathy, and it's like more similar to ankylosing spondylitis. Any more questions? I think about less than 1 minute. Anything? Okay, I think. Thank you, class. Okay, bye.